Those of you who don't know me, I'm Peter Baglien. I'm going to be talking about a complication in spine surgery called pseudoarthrosis. I'm one of the Navy fourth-year residents. Thank you for having me here today. We have a little bit of stuff to get through, so I'll try to, cover everything thoroughly while keeping everyone on their busy schedules. We're going to talk about the definition and epidemiology of pseudoarthrosis, a bunch of the risk factors associated with it, prevention, diagnosis, and then some treatment options for it. So pseudoarthrosis was first described by Hibbs and Albee back in 1911 as a treatment modality for tumor, tuberculosis, trauma, and more severe deformity, although now there's definitely expanding indications for treatment. One thing that I did find interesting is kind of looking at pseudoarthrosis with an O versus pseudoarthrosis. They're used pretty interchangeably in the literature. Most recent Google searches would favor pseudoarthrosis at about 1.2 million hits versus pseudoarthrosis at about 400,000 hits. But it did make the literature search a little bit challenging for certain things, just because how you spell would influence your results pretty considerably. So in any case, linguistically speaking, pseudo means false, arthrosis is joint, and so it kind of creates a false joint around the area that you're trying to get to fuse. In spine, it's usually defined as failure of bony fusion within over 1 year following the index surgery. Rates are incredibly variable in the literature. Depending on what paper you look at, some have almost 100% fusion rates, and some show upwards of 30 to 40% pseudoarthrosis rate. So in the cervical spine, ACDF, we see it both anteriorly and posteriorly, a little bit more on the anterior side. And it's seen in lumbar, again, anterior and posterior lateral. So no matter what approach you're taking for fusion, it's definitely a problem. It's not really a theoretical risk, as most of us, I'm sure, wish it were, but we'll talk about it a little bit more. And I think a lot of that goes into the patient populations that we're seeing and the risk factors associated with it. If you're dealing with a young, healthy patient, likely you'd be on the lower end of that versus a patient with a smoking history, diabetes, et cetera. So we'll talk a lot about the risk factors because I think that's probably some of the most important stuff to focus on, as some of them are modifiable and can be addressed prior to surgery in order to decrease that risk. Certainly, smoking and nicotine is a big issue with any sort of fusion surgery in orthopedics, spine included, and endocrine abnormalities that, maybe 10, 20 years ago we're less focused on. We're starting to see more of a prevalence with non-union and pseudoarthrosis rates in our fusion world. Definitely, there are some mechanical factors that play a role too. Some of these are less modifiable, hip spine pathology, patient alignment, et cetera. And then there's a component of both, with obesity having definitely the metabolic type disease and the mechanical factors as well. So we'll start by talking about nicotine. So this paper was published in 2000 by Glassman et al. Looked at 357 patients with smokers and non-smokers. Found that the overall non-union rate was 14.2 for non-smokers, and pretty significantly increased to 26.5 for patients who continued to smoke after surgery. Patients who quit greater than 6 months had a decreased non-union rate compared to those that didn't, but the ones that quit immediately pre-op did not have an improvement in their non-union or pseudoarthrosis rates. Interestingly, the return to work was improved, though, even in both the non-smoker and the patients who quit smoking, but in the patients that didn't, pretty significant decrease. And so this was kind of the leading paper, I think, that sparked a lot of the discussion on nicotine use, and we'll see a few more examples of that. So this was another paper that looked at 50 smokers and 50 non-smokers that underwent a 2-level laminectomy. And there was a 400% increase pseudoarthrosis rate in the smokers compared to the non-smokers group. This was another interesting paper. So the Glassman paper that I just mentioned did not really show a difference in the amount of cigarette use in terms of number of cigarettes, but this paper did. So this was a 2001 paper that looked at 54% of 396 patients who were smoking preoperatively, and they followed these patients out to 2 years. And they noted that there was about a 2 times increase risk of patients who smoked more than 10 cigarettes a day versus those who smoke less than 10 cigarettes a day were closer with the non-smoker group. This was an interesting paper looked at, published in 2022, looking at the impact of smoking cessation modalities, specifically nicotine supplementation for smokers. And I think that this is interesting because it looks at kind of the effect that nicotine could potentially have on pseudoarthrosis rates, not just like the tobacco in general. So for all-cause complications, there was the cessation group were closer to the smoker group in terms of all-cause complications, but at least in this registry of patients, there was no significant difference in pseudoarthrosis rates between the cessation therapy group and the smokers. So this was kind of looking at cervical spine in general. So this was in specific, rather. So this was a paper looking at 132 patients who underwent uninstrumented ACDF. 45% of the patients were smokers, an average of 1.5 packs per day, which looking at that is over 20 cigarettes a day. So these were also demonstrated statistically decreased fusion rates, with smokers being about 86% versus 100% in the non-smokers group. And this paper I thought was interesting because it noted that allograft, kind of as expected compared to autograft, had a higher rates of the non-union within the smoker group compared to the non-smoker group. So does smoking influence fusion rates in posterior cervical spine? So we just talked about anterior cervical spine. And at least out of this cohort of patients published in 2011, with lateral mass screws and iliac crest bone grafting, they noted that there was no significant difference between the two groups. They had 100% fusion rate in both groups. So maybe an outlier in the literature, but kind of interesting with regards to posterior cervical fixation. So why does this happen with nicotine? So I just briefly wanted to throw this in to kind of talk about probably the role that nicotine has. I think a lot of times we look at the vasoconstriction and decreased angiogenesis as a result of nicotine use, but it's clear that it also impacts a lot of the genes. This was a rabbit model that looked at, and published in 2000, that looked at not only the vasoconstriction and angiogenesis aspect of it, but also the osteoclast activity and a bunch of the genes needed for fusion. And they found that universally in this rabbit model, all the following genes, BMP, FGF, collagen, and VEGF, associated with fusion were all inhibited in this process, as was osteoblast activity. And so it does, I think, note that more than just the vasoconstriction aspect of it plays a role in decreased fusion. And the factors that they were measured 1 week after the fusion procedure was attempted, which other kind of basic science literature shows that the first month is probably the most important for fusion. And so I think that this kind of shows the overall detrimental effect of the nicotine. Looking at some other factors, so obesity plays a role as well. This cohort of 137 patients published in 2017 looked at fusion rates with normal BMI, overweight BMI, and then obese BMI. Interestingly, there was a difference in fusion rates, as you can see here, between 88 and 60%, depending on the cohort of patients. But there was no difference in complications. So even though the patients were more obese, had lower fusion rates, in this patient population, they seem to do about the same. So more probably asymptomatic pseudoarthrosis rates. Overall, though, as a whole, endocrinopathy seems to play a pretty crucial role in pseudoarthrosis. Of the patients that went on to pseudoarthrosis, this paper that was published in 2022 looked at all the different types of endocrine disorders associated with the pseudoarthrosis. And 82% had at least one pre-op abnormality. Some patients had multiple. And then out of patients that were referred to endocrine post-op, they noted that 98% of those referred post-op had some sort of endocrine disorder. And I think it's important to note that a lot of those endocrine orders are modifiable or at least controllable, especially like vitamin D deficiency, to some extent diabetes, osteoporosis, osteopenia. And so I think a large part of the importance of this topic kind of relates to hopefully optimizing patients with those diagnoses. So we'll start by talking about vitamin D. So this was a a paper published in 2019 by Dr. Ravindra. They looked at 133 patients with vitamin D deficiency, which they defined as less than 20 nanograms per deciliter. And they followed these patients out to 1 year. And they noted about a 2 times increase in pseudoarthrosis rates in patients that were significantly vitamin D deficient, excuse me. And they also noted that there was an increased time to fusion at 12 months versus 6 versus 12 months. That did not reach clinical statistical significance in their cohort, but there was definitely a strong trend towards that. So this was another paper kind of looking at vitamin D deficiency and failure and revision rates following vitamin D deficiency. So rather than looking at pseudoarthrosis specifically, this paper kind of looked at whether or not the patients needed revision for any reason. And so, I do think it's notable to mention, but not exactly comparing apples to apples, but they found that failure rate in vitamin D deficient patients was 3.3 versus 2.6 and similar revision outcomes. And they weren't able to isolate from this database study whether or not these patients were treated necessarily just for pseudoarthrosis versus other cause, but certainly I imagine that pseudoarthrosis would play a role in the revision surgery. This one is kind of looking at the cost effectiveness of intervention of posterior lateral lumbar fusion, and it's comparing specifically to need for revision if the patients weren't treated for vitamin D deficiency. So this kind of newer data that looked at the cost saving per 10,000 cases of posterior spinal fusion and treatment with vitamin D. And they found that just treating patients without even screening them ahead of time was the most cost-effective way to treat vitamin D deficiency. And I think this probably relates to the fact that a lot of patients in our population, even in sunny San Diego, where we live, are vitamin D deficient. But even if you go down the screening and treatment route, there's still pretty significant cost savings compared to potentially having the patients go on to revision. So I think this is pretty compelling for treatment of vitamin D, and certainly in the military population where I'm coming from, it's become kind of a standard of care, especially for Marine recruits, for any orthopedic issue to undergo vitamin D repletion. All right, so looking at osteoporosis, which does kind of spring off of vitamin D in some ways. This was a 2020 paper that looked at over 5,000 single lever fusion with a matched cohort study. And they found significantly higher rates of pseudoarthrosis in both osteopenia and osteoporosis compared to a control group. When you could see like the odds ratio of 1.7, 1.9 respectively. I think that this probably relates to that there is some biological component rather than just mechanical component to osteoporosis that is influencing fusion. So what to do about osteoporosis? So this was a meta-analysis that was looking at 7 studies comparing bisphosphonates to a no bisphosphonate control. And they did, I think there's some like older thought process that bisphosphonates could potentially cause issues with fusion. But out of this study, they showed that there wasn't really any increased risk, certainly. And actually, there were some protective factors for pseudoarthrosis with regards to having patients on bisphosphonates prior. There was also decreased risk of vertebral compression fractures, pedicle screw loosening, and cage loosening between the two groups. So is there something better than bisphosphonates? And the answer is probably yes. So there's 2 papers I included here, 2018. One was the first one looking at bisphosphonates and teriparatide use. And this was comparing bisphosphonates to teriparatide, and they found that there was no difference in fusion between the 2 groups compared to each other, but there was higher rates of, there was no higher difference in fusion compared to controls, but there was higher rates of fusion in the teriparatide group with an odds ratio of 2.3. So that kind of got me thinking, is there something with newer medications such as denosumab that could potentially also improve fusion rates? And this is kind of a study, I didn't really find much outside of this study, although it's a pretty well-designed study with a relatively small patient population. But it was a randomized controlled trial that compared 2 groups of teriparatide only with teriparatide and denosumab. And they did find significant difference at 6 months with regards to fusion with teriparatide only at 36% and combo at 82%. It was underpowered to detect a difference at 12 months just because they only 16 patients, but there was a pretty strong trend to even increase fusion at 12 months. And so maybe that's kind of a future. I don't know if this has kind of been seen or done in many institutions, but the early literature on it is pretty supportive of teriparatide with denosumab. And in this patient cohort, they had no adverse events out of the 16. So moving on to PPIs, this is a relatively newer issue that's kind of been brought up with regards to the pseudoarthrosis world as well. And I think it relates back to a couple papers. And this first one was kind of looking at a rat model with 38 rats who underwent posterior lateral fusion. And they compared PPI versus control groups. And they found that fusion was 100% in the control group and 94% in the PPI group, which was not statistically significant, although they did harvest several months after the index surgery for these rats, and so that could potentially have skewed the results a little bit. But what they did note was that there was significant trend towards less bone formation in the PPI group. So even though they were fused, there was less bone there, which I think is pretty explainable by the proton pump pathway. So a lot of times, I think proton pump inhibitors are thought to be associated with decreased absorption of calcium, which eventually causes both primary and secondary hyperparathyroidism. But there's actually, on my dive of looking at causes for weakened bone structure, there's actually multiple different pathways, about 4 or 5, depending on how you count them, that affect it, both vitamin B12 deficiency, gastrin, and then certainly the calcium and parathyroid pathways influencing weakened bone structure. So although those rats went on to fusion, it makes sense why they would have less bone structure with that many obstacles working against them. So this was kind of a newer paper that looked at out of 2024 that looked at this in a human model. So 264 patients, 58 had a proton pump inhibitor and 206 did not. And there was an increased odds ratio of 3.5 with PPI and pseudoarthrosis rates. So this is something to definitely take into consideration with patients that are able to potentially get off of PPIs prior to surgery or switch to a different class of medication. Diabetes. So this, again, we have a nice rat model for with comparing insulin-dependent diabetic rats and bone metabolism and growth after spinal fusion, published in 2020. And they showed an increased inflammatory cytokines in the diabetic group immediately following surgery. So this, again, was 1 week following. And then they also showed a pretty significant decrease in fusion rates, about 2 times higher in the insulin-dependent group. In human models, it's a little variable. There are some papers out there in a meta-analysis that says that there isn't much of a difference between at least non-insulin dependent diabetics and non-diabetic patients. But I think this is probably one of the better studies out there in terms of design. It's a prospective study with 96 patients, direct match cohorts. And they looked at 1-year fusion rates, which was 78% in the control group and 53% in the diabetic group after lumbar fusion surgery. There's also a trend towards higher VAS in the diabetic patient group, but that did not reach statistical significance. And so I do think that there is some counseling aspect of this too, even for patients that aren't insulin dependent, which these weren't, that they may have higher rates of pseudoarthrosis. It wouldn't be complete pseudoarthrosis lecture without talking about NSAIDs and Toradol, which is something that really began kind of back in 1996 off of this rat model that sparked the whole discussion about the negative impacts of Toradol with spinal fusion. So these rats underwent very high dose indomethacin, about 2 times the dose that is typically given to people. And they found that there was a 45% fusion in the control group versus only 10% in the indomethacin group. And so the question kind of became is, does this kind of play out with more normal doses of NSAIDs, and what about lower dose NSAIDs? So this was a 2011 study that looked at high dose Toradol and spinal fusion, and it was a meta-analysis of 5 retrospective studies that looked at over 1,400 patients, and all these patients received NSAIDs for less than 14 days following surgery. In the patients that had high dose Toradol, they did note there was almost 3 times relative risk of going on to pseudoarthrosis versus normal dose Toradol or NSAIDs. There was no difference. And I think this is probably one of the best papers out there in this whole PowerPoint, but this was a randomized controlled trial looking at 246 patients that compared just low-dose Toradol for 48 hours afterwards. Now, they were looking at a select patient population of just 1 to 3 level MIS TLIF with BMP supplementation, but it found that there is no difference in fusion at 6 months and 1 year. And there was a significant decrease in post-operative opioid use while not compromising level of pain. And then there was a decreased total length of stay in the hospital. So I think that this is pretty compelling evidence that it's okay, at least in select patient populations, to give low-dose Toradol in order to help with post-operative pain. I don't know how translatable this is to big spinal deformity cases, but I think that it's worth noting that this is potentially a good option for patients that have pretty significant pain post-operatively. Other risk factors, fusion length does seem to play a role. So this was a study that looked at 144 patients published in 2006 that underwent a long fusion from 5 to 17 vertebra with a minimum of 2-year follow-up. They found like an all-cause pseudoarthrosis rate of 24%. And the risk factors kind of seen here. So at the thoracolumbar junction with a kyphosis of greater than 20 degrees, osteoarthrosis of the hip that we talk about pretty regularly in terms of hip spine syndrome, thoracolumbar approach, age greater than 55, persistent sagittal imbalance, and then incomplete sacropelvic fixation. And then one thing that is noted kind of on the table on the right is that the number of vertebral fused, kind of to no surprise, trended towards, if you get close to greater than 15, there's an increased risk of pseudoarthrosis. I don't find that entirely surprising, given that if you're fusing more levels, there's a greater chance that one of those levels could go on to pseudoarthrosis. But I think that some of these factors are potentially modifiable either through surgical technique, although certainly some of them are not, such as age and osteoarthritis of the hip. So what can we do about that? So this was a paper published in 2017, retrospective review of 31 patients, a relatively small cohort that transitioned from performing dual rod to a multi-rod construct. And they found that there was no pseudoarthrosis in that patient population and no rod fracture in that patient population. In the dual rod group, they did have some fractures at the lumbosacral junction, and out of 4 of those, 3 were explored surgically and found to have hypertrophic non-unions. So I think it was mostly a stability problem rather than a biologic problem. Other risk factors, so this is kind of both a mechanical and a biologic issue to address, because specifically for long adult spinal deformity case, but the use of BMP2 versus iliac crest autograft. So this was 55 consecutive adult spinal deformity patients who underwent fusion with either iliac crest bone graft or BMP2. They found no difference between the two groups in terms of age deformity or number of spinal levels fused, but they did find a significantly decreased rate of pseudoarthrosis in the BMP group and much higher in the autograft iliac crest bone group. So there's another paper out there I didn't include in this talk that talked about BMP2 as a supplement for patients that are going to be on postoperative NSAIDs. And that also found that BMP2 could potentially counteract the effects of NSAIDs as well. So I think that that's a good option for these fusion cases. Other risk factors, pedicle subtraction osteotomies. So this was a paper published in 2014 that looked at 171 adult spinal deformity cases that underwent pedicle subtraction osteotomies. They found an overall pseudoarthrosis rate of about 10%, but the majority of those occlude at the pseudoarthrosis site. And so I think that there's a practice trend I saw from some technique guides that talked about ensuring that there's good bone graft in BMP2 placed at those higher risk pseudoarthrosis sites, as well as this TL and LS junction, in order to promote fusion. All right, so we'll talk about diagnosis now. I think that the takeaway kind of preview for this is that it's really difficult to assess on imaging modalities in isolation. You got to rule out infection, and the gold standard is still intraoperative findings. But I think why it's hard to assess, especially on just radiographs, can be well described in this paper, which is published in 2007. And it was looking at the threshold of movement on various spine models for how much kind of elastic deformity the bone underwent intrinsically. And within these 4 different fusion types, there really was no significant measurement that could be used to determine if the segments had adequately fused. There was significant variation in the amount of motion with identical fusion techniques and within the same fusion technique groups. And so in essence, standing radiographs on flexion extension films are likely unable to be able to detect motion adequately. So this paper series, rather, I should say, came out of the Journal of Neurosurgical Spine, and it was looking at, grade of recommendations for fusion procedures. So the little box on the top left was kind of the top right was the first edition of it, which looked at what their level of evidence was for providing these recommendations. And their grade A recommendation was following lumbar fusion surgery, static lumbar radiographs are not recommended as a standalone method to assess fusion status, which kind of makes sense. It's difficult to see through the various shadows of tissue in order to adequately assess the fusion. Their grade B recommendations, so for ALIF and posterior lateral fusion, fine cut CT was recommended. And they noted specifically that for posterior lateral fusion, the presence of intertransverse bone was suggestive of fusion. And the ALIF population, anterior sentinel sign was the most sensitive, so bridging bone anteriorly, versus posterior sentinel sign was being the most specific. Grade C recommendations was basically just don't do bone scans. They're not reliable in this setting. So how should we diagnose these? So this was a 2008 paper published in Spine that looked at anterior cervical fusion assessment, and this was a prospective clinical trial that looked at various imaging modalities to assess which was the most accurate. So the takeaway is really that, all these pre-op imaging was evaluated between 3 different spine surgeons who were not involved in the patient care, and then that was correlated with their intraoperative findings. And as you can see in the table on the left, the bottom left, that even the best, which was CT, did not correlate 100% with fusion. So intraoperative findings are still the gold standard. Again, so CT scan, this was another one that looked at CT specifically, and they looked at specific criteria with regards to CT scan. So whether they had complete absence of continuous bony trabeculae, peri-implant lucency, and then motion on dynamic films. And even CT scan, as the previous study showed too, only had about a 57 to 80% correlation with intraoperative findings. And so just because the CT is telling you something, the clinical suspicion for pseudoarthrosis has to be there as well. This is a brief summary table. I won't spend too much time on that, but some of the clinical features associated with radiographic findings of pseudoarthrosis. And then we'll move on to treatment. So treatment is kind of when. So looking at the cervical spine specifically, when is an appropriate time to go back and treat these patients that have pseudoarthrosis problems? So this was a 2018 study looking at 89 patients with 1 to 3 level ACDFs, and they evaluated the fusion at 1 to 2 years, 1 and 2 years rather. At 1 year, they found a 32% pseudoarthrosis rate, but at 2 years, without any intervention on those patients, 72% of that cohort fused. They did note that if patients didn't fuse by 2 years, they had significantly worse VAS and NDI scores. But I think that this shows, just because they're not fused at 1 year, it's not an indication necessarily to take them back. A large portion of those patients will eventually go on to fusion. So when these patients eventually do need surgery, what's kind of the thought process for that? So this was a cohort of 120 patients that underwent ACDF. 27 patients underwent repeat anterior procedure, 93% underwent posterior spinal fusion at a minimum 2-year follow-up after revision surgery. And they found that there was no significant difference in the number of levels. Smoking status, there was a decreased complication rate in the anterior group compared to the posterior group. However, 44% of the revision anterior patients required re-revision versus only 2.1% in the posterior spinal fusion group required re-revision, which I think is an interesting takeaway. It makes sense, though, to me that if you're kind of supporting the whole structure of bone, you'll get increased rates of fusion. So again, this was another study looking at cervical arthrosis treatment with posterior spinal fusion. This was 33 patients that underwent posterior spinal fusion. with either iliac crest or just local bone grafting with follow-up out to 46 months. And then they found that 100% of these patients fuse at final follow-up. There is no difference from iliac crest bone grafting versus local bone grafting. But they did note that there was pretty significant residual pain and poor satisfaction with this patient population, likely due to the pain that kind of comes with the posterior spinal fusion. And so part of me wonders if, the results of the previous study that I just mentioned, those patients not going on to any sort of revision surgery is due to the fact that they had increased pain and didn't want to go on to a previous subsequent surgery. With regards to the lumbar spine, and treatments for pseudoarthrosis. So this was a 2011 study that looked at 47 patients that underwent revision fusion for pseudoarthrosis. Mean duration after surgery was over 2.5 years, and they found significant improvement in posterior vision, VAS scores, ODI, and SF12. But the patients did require narcotics out to 12 months. No patients required revision for pseudoarthrosis in this patient population. So if you take an ALIF and you fuse it circumferentially with a posterior spinal fusion, these patients also seem to do well. In this small cohort of patients, they found 100% fusion rate at 2 years following circumferential fusion after isolated ALIF. These patients also had improvement in back and leg symptoms. So one thing I was curious about is whether or not having these revision surgeries makes the patients worse off in the long run. And I think the answer is probably no. Based off of this study, certainly it's an additional surgery that they have to undergo, but at least in this cohort of 175 patients, published in 2021 with minimum 2-year follow-up, they found that these patients had statistically significant improvement in their SRS-22 and ODI scores, and that a 2-year minimum important clinical difference between patients with reoperations and without was not statistically different. So if these patients had never had to undergo a second surgery, they were not significantly different than the cohort of patients that did have to undergo or did not have to undergo a second surgery. So I think as long as they eventually reach fusion, they will do pretty well. And I think that's important to help be able to counsel patients on as well. What about infection? So cold infection does exist in pseudoarthrosis. There is a substantial amount of false positives or contaminants in this population at about 20%, but there is about a 10% true infection rate. And so I think ruling out pseudoarthrosis is important. Most commonly, it was a slight elevation in CRP that kind of denoted the infection. It's associated also with increased BMI and then fusions at the thoracolumbar junction. And so ruling that out before proceeding down the surgery route, I think is important in this patient population, just like we would for any non-union in a long bone. So my take-home points from this topic were patient optimization prior to surgery is key, controlling the modifiable risk factors for pseudoarthrosis, and then I think intraoperative techniques are important for helping the stability and the biology in order to address healing for the non-modifiable risk factors. I think imaging can be misleading. Clinical reasoning and intraop findings are still the gold standard. And then patients can still achieve good outcomes following revision surgery if they end up needing that for their pseudoarthrosis. Thank you very much.
Yeah, that's great, Peter. Very nice deep dive.
Thank you.
You're not coming in clear.
Sorry, it was cutting in and out for a second.
Still,
Andy, we lost you.
Hey, Peter, did they give you any guidelines on smoking cessation with respect to like how long before surgery? Did you come across anything like that?
I think the thing that I noted was at least 6 months prior to surgery would be the most optimal time to stop. That's when at least some of the earlier papers demonstrated that was when you started to get trends towards fusion that were closer to the non-smoking population. The ones that the patients that quit immediately pre-op did not really have a significant difference. So I'd say probably at least 6 months would be ideal if a patient is able to do that.
Okay, thanks. Yeah, that's interesting. I mean, that's a relatively long time for some of these people in a lot of pain, but makes sense in context of a bigger surgery.
Yeah, I didn't come across anything that looked at, 3 months versus 6 months versus 1 month. That would be a good study. But I didn't come across anything like that specifically.
Yeah, fair enough.
I had a interesting. So, what do you guys? What's the group do? Do you guys use Toradol or no?
Yeah, I used Toradol early.
Okay.
Just,
Yeah.
48
I mean,
hours.
at Columbia, it was an automatic part of the order set for essentially everybody. So it's kind of nice to see that the literature, is kind of supportive of that. Also, Peter, thank you for bringing up the pseudo versus pseudoarthrosis, because if we used to say pseudoarthrosis, we would get yelled at. but it's clearly they're both used, because it's funny because when they say pseudo, but then they wanted us to say pseudoarthrosis. So, but
Yeah.
just interesting thing that you brought up. Thank you. That was a great talk.